Welcome back to the deep dive. We are so glad to have you with us today.
Hello, everyone.
Today, we are putting on our scrubs, figuratively speaking, of course, unless you're actually wearing them right now, in which case, respect.
A lot of our listeners might be.
That's true. We're heading straight onto the clinical floor. We're tackling a body system that never, ever sleeps. It works 24/7.
Literally.
And the scary thing is, when it fails, it tends to fail hard. We are doing a deep dive into lower respiratory tract infections and disorders.
This is essential knowledge. I'd call this lung defense 101.
Lung defense 101. I like that.
And honestly, if you're a nursing student listening to this isn't just some niche topic you can skim over. This is your bread and butter.
Right.
You're going to see this in med-surg. You'll see it in the ICU. You'll see it in geriatrics. It is absolutely everywhere.
Absolutely. And just to establish the why before we get into the how, because I think that context is what makes the information stick. I was looking at the source material we pulled for this, and the statistics are, they're honestly staggering. I think we tend to dismiss pneumonia as just a bad cold sometimes.
For sure. People say, oh, a touch of pneumonia.
Exactly. A touch of pneumonia. But the data says otherwise. In 2021, pneumonia and influenza combined were still ranking among the top 10 leading causes of death in the United States.
Wow.
We're talking over 41,000 deaths in a single year.
That really highlights the stakes, doesn't it? It's not a minor inconvenience. For a nurse, the respiratory system is often the canary in the coal mine.
The first sign that something is wrong.
It's usually where the slide begins, and that is a concept I want us to keep coming back to today, the slide.
That slide. Okay.
Because respiratory failure rarely just, happens out of nowhere. It's a progression. A simple cough can turn into a collapse, which turns into an infection, which can spiral into respiratory failure.
And that is exactly our roadmap for this deep dive. We are going to map out that slide so you can spot it before it's too late. We'll start with the precursor, which is atelectasis, the collapse.
Right.
Then we'll move into the main event, pneumonia. We need to decode that alphabet soup of acronyms that always shows up on exams. CAP, HCAP, HAP, and VAP.
That alphabet soup is crucial. And we'll also break down the critical VAP bundle, which is a huge exam topic and, frankly, a lifesaver in the ICU.
Good. Then we'll look at complications like pleural effusion.
And MPMA?
We'll discuss the hidden threat of aspiration, which is something I think scares every new nurse because it can happen so silently.
It really can.
And finally, we'll look at what happens when the lungs just give up. Acute respiratory failure and the basics of intubation care.
It's a full journey. From the first shallow breath all the way to the ventilator.
So let's unpack this. We start with the precursor, atelectasis. Now, purely based on the word, it sounds complicated. It sounds like a dinosaur.
Yes.
The atelectasis rex. But mechanically, what is actually happening here?
It does sound prehistoric, doesn't it? But it's actually really simple mechanics, even if the word is a mouthful. Atelectasis is just the closure or collapse of alveoli.
The little air sacs, the little balloons where the magic happens.
Right. Think of your lungs like a massive bunch of grapes. Millions and millions of them. When they're healthy, those grapes, the alveoli, are plump, they're round, they're full of air.
Okay.
They have surface tension that keeps them open. Atelectasis is what happens when those grapes turn into raisins. They just deflate.
Oh.
And when they deflate, the walls stick together. And once they stick, they can't exchange gas, oxygen can't get into the blood, and CO2 can't get out. Game over for that little sac.
The source material really emphasizes that this is most commonly seen postoperatively. Why is surgery such a specific trigger for this? Is it just the anesthesia making everything lazy?
That's a huge part of it. It's kind of a perfect storm of factors, really. Anesthesia is definitely part of it. It creates a sort of respiratory laziness. It also slows down the mucociliary escalator.
But what now? That sounds like a ride at an amusement park.
I wish. No, it's this amazing defense mechanism. You have these tiny hair cilia in your airways, and they beat in unison, rhythmically, to sweep mucus up and out of the lungs.
So you can swallow it or cough it out.
Exactly. It's your body's self-cleaning oven mode.
Mm.
Anesthesia puts those little hairs to sleep. So secretions just start to pool. They just sit there.
Okay, so that's part one, but you said that's not the whole story.
But honestly, the bigger factor post-op is pain.
Pain. How does pain cause lung collapse?
Well, think about it. If you just had abdominal surgery, maybe a C-section or an appendectomy or even thoracic surgery, Does it feel good to take a big, deep breath?
Definitely not. You feel like your stitches are going to rip right open. You feel like your insides are pulling apart.
Exactly. So what do you do instinctively?
You guard. You take tiny little breaths. You sip the air.
You sip the air. I love that phrasing. You don't expand the lungs fully. And that shallow breathing means the alveoli at the very bottom of the lungs, the bases, they aren't getting fully inflated. They aren't getting that stretch they need to stay open.
Okay, so they're getting lazy.
Now, combine that shallow breathing with a mucus plug that's blocking the entrance to that little grape sac.
And the air gets trapped inside?
Well, the air that's trapped inside the sac gets absorbed into the bloodstream because blood flow continues. But because of the mucus plug, no new air can get in.
Oh, I see.
So the pressure inside the sac drops and the sac collapses. It just shuts down.
That is a terrifying image, just snapping shut. So shallow breathing plus mucus equals collapse. What does this look like in a patient? Is it super dramatic? Are they gasping for air immediately?
It really depends on the speed and the extent of the collapse. You have acute and chronic forms.
Okay.
Acute atelectasis can be very dramatic. You'll see respiratory distress. You'll see tachycardia
Oh, hard.
and tachypnea. That's rapid breathing. They might complain of pleural pain, which is sharp and localized. If it's really severe and a large area of the lung has collapsed, you might even see central cyanosis.
And that's the blue tint to the skin.
Yes, specifically around the mouth and the mucous membranes. It's a late sign, and it means they are not oxygenating their blood properly at all.
And the chronic version, is it less obvious?
That one is much sneakier. It can mimic the acute signs, but is often more subtle. The patient might just seem off or a bit tired, a little short of breath. The real danger with chronic atelectasis is that collapsed, stagnant lung tissue is a breeding ground for bacteria.
It's a stagnant pond.
It is exactly a stagnant pond. Mosquitoes love stagnant water. Bacteria love stagnant lungs. It directly predisposes the patient to pneumonia.
Which brings us to the nurse's role, prevention. Because if the problem is shallow breathing and not moving, then the solution seems pretty physical. We have to be the coaches here.
It is entirely physical. The nursing interventions here are basically a workout plan for the lungs. The number one, first line of defense is mobilization.
Getting them out of bed.
Frequent turning and early mobilization. Get them up, get them walking. I know the patient doesn't want to move. I know they're in pain. But you absolutely cannot let a post-op patient just lie there, flat on their back.
Because gravity helps?
Gravity helps move fluid, and the act of moving stimulates deeper breathing.
Okay. And then there's the famous gadget that I think every nursing student has seen, and probably every patient has been thoroughly confused by, the incentive spirometer, the IS.
Yes. The little plastic box with the ball and the tube. It looks like a toy, but it's a critical medical device.
I feel like I see people using this wrong all the time in movies or on TV shows. They're blowing into it like it's a party horn, trying to shoot the ball up.
That is the number one mistake, and it drives respiratory therapists and nurses completely crazy. You do not blow into it. It is an incentive for inspiration.
Inhale.
Hence the name.
Yeah.
You got to teach the technique properly, or it's just a useless piece of plastic.
Yeah. Okay, so walk us through the proper coaching for this. Imagine I'm your patient, I'm groggy, I'm in pain, and you've just handed me this plastic tube. How do you explain it?
First thing, position matters.
Yeah.
I'd help you sit up, semi-Fowlers or high Fowlers, as upright as you can tolerate. You need gravity to drop the diaphragm so the lungs have room to expand.
Right. If you're slumped over, your gut is in the way.
Exactly. The abdominal contents push up on the diaphragm and you can't take a deep breath. It's just physically impossible.
Okay, so I'm sitting up, now what?
Then I tell you to seal your lips firmly around the mouthpiece. Don't let any air leak out the sides. And then breathe in slowly and deeply. Through your mouth.
Not your nose.
Through your mouth.
Yeah.
And as you do, watch that yellow ball with a piston rise up. We usually set a little target marker for you to aim for.
And there's a specific instruction about holding at the top, right? I remember that from school.
Yes. This is the secret sauce. This is the most important part. You hold the breath for about 3 seconds at the peak of your inspiration. You want to try and keep that ball suspended between the lines.
Why not just pump it up and down really fast?
It's a great question. Think about blowing up a brand new balloon. The hardest part is that initial pop, right? To get it started.
Yeah.
That pause at the top of the breath maintains what we call transpulmonary pressure. It holds that pressure in the alveoli to pop those collapsed sacs back open. It stretches them out and keeps them open.
That makes so much sense. Pop the balloon. And how often do they need to do this? Is this like a once a day and you're good kind of thing?
Oh, no. This is a job. The standard recommendation is 10 times in succession every single hour while they're awake.
Every hour.
Every single hour. It's tedious. Patients hate it. They will roll their eyes at you. But you have to explain the why. You tell them, we are doing this so you don't get pneumonia and have to stay in the hospital for another week. That usually motivates them.
I bet it does. And for those post-op patients we talked about, the ones with the abdominal incisions, you have to teach them splinting.
Oh, a crucial skill. You absolutely have to. Splinting means taking a pillow or a folded blanket and having them hug it firmly against their incision site while they cough or use the spirometer.
It's like a brace.
It acts as an external brace. It physically supports the muscles so they don't feel like they're going to burst open. It reduces the pain just enough that they're willing to take that deep therapeutic breath.
That is a pro tip for sure. So we were mobilizing, we were spirometering. Is that a verb?
We'll make it a verb today. It works.
We're using the spirometer. If all of that fails, what happens? If the lung stays collapsed?
If the basics fail and the lung stays collapsed, we have to escalate. The goal is always to improve ventilation and remove those secretions.
Right.
We might use something like PEEP positive and expiratory pressure, which is a mask that pushes a little bit of air in to hold the airways open.
Or CPAP.
Or CPAP, right.
Yeah.
Or if there's a massive mucus plug that they just cannot cough up, the doctors might have to do a bronchoscopy.
So they go down with the camera.
And a little vacuum to physically go in and suck the plug out. It's very effective, but obviously we would much prefer the patient just coughs up on their own.
Of course. Okay, so that's atelectasis. Ideally, we prevent it. But if we don't, or if the patient is just unlucky, those stagnant, collapsed areas become a petri dish.
Yeah.
And that leads us to the big one, the condition that kills thousands, pneumonia.
Pneumonia. The definition is pretty straightforward.
Yeah.
It's an inflammation of the lung parenchyma. That's the functional tissue of the lung caused by a microorganism.
So bacteria, viruses.
Bacteria, mycobacteria, fungi, viruses, all of the above.
And for students, this is where that alphabet soup gets really thick. The sources make a huge deal out of classifying pneumonia. We have CAP, HCP, HP, and VAP. Why do we need so many acronyms? Is the treatment really that different, or is this just academic hair splitting?
Oh, it is wildly different. And knowing the difference is key to passing your exams and, more importantly, not harming your patient.
Yeah.
It's all about context. The context tells you what bug is likely causing the infection, which then tells you what antibiotic to use. If you use the wrong weapon, the bug survives and the patient gets worse. It's that simple.
Okay, let's play detective then. Let's run through them. First up, CAP, community-acquired pneumonia.
This is exactly what it sounds like. It's an infection that occurs in the community or, and this is the specific rule you have to remember, within the first 48 hours of hospitalization.
So if you come into the ER and you already have pneumonia or you develop it the next morning on the floor, that's still considered CAP.
Correct. The assumption is you brought the bug with you from the wild. You inhaled it at the grocery store or at your kid's school. The most common bacterial cause here is a classic, Streptococcus pneumonia.
And we see this a lot in older adults, right?
Huge numbers. The incidence really rises with age. We see a lot of hospitalizations for adults over 65 with CAP.
Okay, so Creek AP is from the wild. Then we have this middle ground, HCAP, healthcare-associated pneumonia. This one feels a bit blurry to me. It's not hospital-acquired, but it's not exactly community either.
Right. HCAP is a really important category for patients who are not currently hospitalized, but have extensive regular contact with the healthcare system.
So like someone in a nursing home.
Exactly. Think about someone who lives in a nursing home or a long-term care facility, or someone who goes to a hemodialysis center 3 times a week, or someone receiving home wound care or home IV antibiotics.
Why do we have to separate them from the general community? Why isn't grandma in the nursing home just considered community acquired?
Because the bacteria hanging out in nursing homes and dialysis centers are tougher. They are battle-hardened. These patients are at a much, much higher risk for MDROs, multi-drug-resistant organisms.
Ah, superbugs.
The superbugs,
Yeah.
exactly. So if you treat a nursing home patient who comes in with pneumonia with the standard community antibiotic, it might not touch the resistant bug they actually have. You have to assume they have something nastier. You have to start with bigger guns.
That is a critical distinction. Okay, next is HAP, hospital-acquired pneumonia.
This one is pretty clear-cut. It's pneumonia that develops 48 hours or more after admission. And the key qualifier is that it did not appear to be incubating at the time of admission.
So they came in with, say, a broken leg, lungs were totally clear. 3 days later, they spike a fever and have a nasty cough. That's HAP.
Precisely. And HAP is dangerous. In some contexts, it's considered a preventable error or a never event, meaning insurance might not even want to pay for the treatment because the hospital caused it, in a sense.
What puts patients at risk for HAP?
Predisposing factors include being supine, lying flat on your back for too long, being in a coma, malnutrition, and just a prolonged hospital stay in general.
And the bugs are different again, I assume.
Nasty ones. We're talking E. coli, Klebsiella, and MRSA.
So the mortality rate must be high.
Very high. Because you have to remember, the patient is already sick. That's why they're in the hospital.
Yeah.
Now you add a resistant lung infection on top of their original problem. It's a really bad combination.
And then underneath that umbrella of HAP, we have the specific monster, VAP, ventilator-associated pneumonia.
VAP. This is a subtype of HAP, but it's specifically for patients who have been intubated and on mechanical ventilation for at least 48 hours.
This seems to be a huge focus in nursing education right now, preventing VAP. It's everywhere.
It is a massive quality indicator for hospitals. If a patient gets VAP, it complicates their recovery, it extends their ICU and hospital stay, it costs the system a fortune, and it significantly increases their risk of death.
Which brings us perfectly to the bundle, the VAP bundle.
If you are planning to work in the ICU, or really anywhere in critical care, you need to know this bundle inside and out. Memorize it.
It's a checklist, right? A list of evidence-based interventions that, when you do them all together, they just tank the rates of VAP.
That's it. It's not a suggestion box. It's a protocol.
So let's go through the 5 elements. I want to drill these down. Number 1, elevation.
Head of the bed, or HOB, elevated to 30 to 45 degrees at all times, unless there's a medical reason not to.
Why? What's the magic of 30 degrees?
Simple physics. It helps prevent gastric reflux. If the patient is lying flat, it's easy for stomach contents to come up the esophagus and then trickle down the trachea, past the tube, and into the lungs.
Aspiration.
Right. Gravity helps keep the stomach contents in the stomach where they belong.
Okay, that's easy enough. Number 2, sedation vacations. Which sounds like a nice trip to the beach, but I'm guessing it isn't.
Not for the patient, no. This is a daily interruption of sedation. Every day, usually in the morning, we lower or completely stop the sedative drugs like propofol to assess the patient's neurological readiness to be extubated.
So we wake them up a little bit to see if they can breathe on their own.
Essentially, we want to know, are you in there? Can you follow commands? Are you ready to get this tube out? Because every single hour that tube is in, the risk of pneumonia goes up. We don't want them sedated and vented for 1 minute longer than is absolutely necessary.
Makes sense. Number 3, peptic ulcer prophylaxis.
We give medications like proton pump inhibitors or H2 blockers to prevent stress ulcers from forming in the stomach. Again, it's about preventing gastric colonization and reducing the acidity of any reflux that might happen.
So it's another layer of protection against aspiration damage.
Exactly.
Number 4, DVT prophylaxis.
Preventing blood clots in the legs, using compression devices or anticoagulant medications.
Now wait, how does preventing a leg clot prevent lung pneumonia? That connection seems less direct.
It's a great question. The exact mechanism is complex. It probably involves reducing systemic inflammation and the effects of immobility, but the evidence is clear. When we are vigilant about preventing DVTs, VAP rates drop. It's just part of good, holistic, critical care hygiene.
Okay. And number 5, which I feel like falls on the nurse more than anyone, oral care.
This one is huge, and it's so often overlooked. Daily oral care with chlorhexidine, which is a specific antiseptic rinse.
Why does brushing their teeth matter so much for their lungs? I think some students and maybe even some nurses struggle to make that direct connection.
Because the mouth is dirty. It is full of bacteria. If plaque is allowed to build up on the teeth and tongue, it becomes a biofilm, a reservoir, basically a hotel for bacteria.
And the breathing tube is right there.
The breathing tube is sitting right next to that reservoir. And those bacteria can migrate down the outside of the tube just a little bit at a time and get seeded directly into the lungs. A clean mouth equals clean lungs. It is that simple and that important.
That connects the dots perfectly. So we know the types, we know the prevention. Now let's talk about what pneumonia looks like when it hits, the clinical manifestations.
Classic. Textbook pneumonia presents with a sudden onset. We're talking sudden chills, a rapidly rising fever, and pleuritic chest pain.
And pleuritic pain means it hurts to breathe, right?
Yes, it's a sharp, stabbing pain that gets much worse when you take a deep breath or when you cough. It's due to the inflammation of the pleura, the lining of the lung rubbing against the chest wall.
And their breathing gets fast.
Tachypnea, yes. And usually a productive cough, a cough that brings up sputum.
And the sputum analysis can tell a story too, can it?
It really can. It's usually purulent, So thick, yellow, or green. But specific signs can give you clues. For example, that classic rusty or blood-tinged sputum often points directly to that streptococcal infection we mentioned earlier. It's a very specific sign to watch for.
And when you put your stethoscope on them or do your physical exam, what are the red flags?
You're looking for signs of consolidation, which just means solidification of the lung tissue with fluid and pus.
Instead of air.
Right. So on percussion, when you're tapping the chest, you hear dullness instead of the normal, hollow, resonant sound of air. On auscultation, with your stethoscope, you'll hear bronchial breath sounds over the affected area, or crackles.
And there's this term that always comes up on exams, tactile fremitus.
Yes.
What's the deal with that?
So you have the patient say 99 over and over while you feel their chest wall with the ulnar side of your hand, the bony part. If there's consolidation fluid or solid tissue, the vibration is actually increased.
Wait, increase? I would have thought fluid would dampen the vibration. That seems counterintuitive.
It is a super common misconception, but think about it this way. Sound and vibration travel better through a solid or a liquid than they do through air.
Oh, like hearing a train coming through the tracks before you hear it through the air.
Exactly. Or how sound travels so well underwater. It's the same principle. So increased tactile fremitus is a key sign of a solid lung of pneumonia.
That's a great way to remember it. Now, here's a curveball that students absolutely need to watch out for, the gerontologic twist.
This is so important. Older adults often present atypically.
Meaning they don't follow the textbook rules.
Not at all. They might not have a high fever. Their immune system just doesn't mount that same robust heat response anymore. They might not even complain of classic chest pain.
So what do you look for if they don't have the main signs?
Confusion.
Confusion.
General deterioration. Weakness. Abdominal symptoms like anorexia, they just stop eating. But the number one thing to watch for is a change in mental status. Confusion. Delirium.
So if grandma is suddenly confused, delirious, or acting way out of character, and she has a high heart rate and is breathing fast,
You need to check her lungs immediately, even if her temperature is normal.
so confusion is the fever of the elderly.
I like that, yes.
Huh.
That's a great way to put it. Hypoxia makes you confused long before it makes you blue. If you wait for the fever in an elderly patient, you might be waiting too long.
So we've diagnosed it, now we have to manage it. What is the game plan for treating pneumonia?
It always starts with antibiotic stewardship. We don't just throw everything at it. Ideally, we get a sputum culture and sensitivity first to identify the specific bug and what kills it.
You can't wait for that result, right? It takes days.
Exactly. So for something like HAP, we usually start with a broad-spectrum IV antibiotic to cover our bases, because time is tissue, or in this case, time is lung. And then we de-escalate to a more targeted drug once the lab results come back.
And the goal is to switch from IV to oral meds as soon as they are stable.
Right. As soon as their temperature is down, their heart rate and respiratory rate are stable, and they can swallow and keep things down, we switch them to oral. Get that IV out. Get them moving towards discharge.
But aside from the drugs, there is the art of nursing, all the supportive care. And one thing the source mentions repeatedly is hydration, force fluids.
Yes. Unless they have a contraindication like heart failure or renal failure, yes. We want them drinking at least 2 liters a day.
Why is water so important for the lungs?
2 main reasons. One, the fever and the rapid breathing cause insensible fluid loss. You lose a lot of water just by panting and sweating that you don't even realize. You have to replace that to prevent dehydration.
Okay, that makes sense.
And 2, and this is the big one, hydration thins the mucus. It acts as a natural expectorant. If a patient is dehydrated, their secretions turn into cement. It's thick, it's sticky, and it's almost impossible to cough up.
But if they're hydrated?
If they're well hydrated, the mucus is thinner, more watery, and much easier to clear from the airways.
So drink up. And what about adding humidification?
Same exact principle. Putting a high humidity face mask on them helps to directly liquefy those secretions in the airway. It also feels very soothing and can relieve airway irritation.
And we also have to teach proper coughing techniques. It's not just telling them to cough.
No, it's directed coughing. We teach them to position themselves correctly, sitting upright. Take a slow, deep inspiration, then close the glottis, hold it for a second, and then give a forceful, explosive expiration. Use those abdominal muscles.
It's about generating enough pressure to blast the mucus out.
Exactly.
And for the patients who really can't get it up on their own.
For them, we might use chest physiotherapy or CPT. This is a bit old school, but it can be very effective.
How does it work?
It uses gravity. We call it postural drainage. where we tip the patient into different positions so the affected lung segment is higher than the main airway, allowing gravity to drain the mucus down and out.
And then you do percussion.
And we combine that with percussion cupping the hands and rhythmically clapping on the chest wall over that lung segment to literally shake the secretions loose.
It's basically controlled drumming on the patient's back.
Controlled drumming is a good way to describe it, yes.
Yeah.
It vibrates the chest wall to dislodge that thick, sticky mucus.
Let's talk nutrition. I imagine eating isn't a top priority when you can't breathe.
It is not.
Uh-huh.
Dyspnea, the feeling of shortness of breath and the profound fatigue, just kill the appetite. But they desperately need calories to fight the infection.
So what's the strategy?
Small, frequent meals. Don't put a giant Thanksgiving dinner in front of them. It's overwhelming. Give them nutrient-dense fluids, things like Ensure or even Gatorade concepts. Getting electrolytes and calories in liquid form is often much easier than chewing a steak.
And rest.
Rest is medicine. We keep them in a semi-Fowler's position to help with lung expansion. But we keep activity to a minimum during that acute phase. They need to conserve all their energy for gas exchange and fighting off the bacteria, not for walking laps around the unit.
Okay, so most people recover with antibiotics and good supportive care. But sometimes things go sideways. Let's talk about complications, specifically pleural effusion and empyema.
Right. These are problems of the pleural space, that thin potential gap between the outside of the lung and the inside of the chest wall.
There's normally a little fluid in there, right?
Just a tiny bit of lubricating fluid so the lung can slide smoothly when you breathe.
But in a pleural effusion,
Fluid accumulates. Way too much fluid. It fills that space and it presses on the lung, preventing it from expanding fully. It's like wearing a corset that is way, way too tight.
and empyema, how is that different?
Empyema is much worse. It's when that pleural fluid becomes thick, purulent pus. It gets loculated, which is a key term. It means it forms pockets with these thick fibrin walls. It's a complicated walled-off infection.
How do we fix that? I mean, antibiotics can't really get into a pocket of pus that's inside a wall, can they?
But not very well. We usually need to drain it. For a simple effusion, we can do a thoracentesis.
That's the needle aspiration.
Yes. A doctor inserts a needle through the chest wall into that fluid space to suck out the fluid, both for analysis and for therapeutic relief.
And what's the nurse's role there?
The nurse's role is crucial. Explain the procedure, help position the patient, keep them absolutely still during it, that's critical, and afterwards monitor them very closely for a pneumothorax.
A popped lung.
Exactly. Sticking a needle that close to a lung carries a risk. If the lung gets punctured, air escapes into the chest cavity and can collapse the lung. So you have to watch for sudden shortness of breath or uneven chest movement right after the procedure.
And for the thick, walled-off empyema,
A single needle stick usually isn't enough. For that, we need a chest tube. A larger tube is inserted and left in place to drain the pus continuously. And these patients often need 4 to 6 weeks of heavy-duty antibiotics. It's a long, long road.
wow. Okay, moving on to another massive topic in respiratory health.
Yeah.
Aspiration. We touched on it with VAP, but let's go deeper. What's the formal definition of aspiration?
It is the inhalation of any foreign material into the lower airway. That could be stomach contents, food, saliva, anything that's not supposed to be there.
And the consequence is usually pneumonia.
Yes, aspiration pneumonia. It can be a chemical pneumonitis from the stomach acid literally burning the lung tissue, or it can be a bacterial pneumonia from all the bugs in the mouth or stomach contents. Either way, it causes massive inflammation, fluid buildup, and infection.
Who is most at risk for this?
Anyone with a decreased level of consciousness, patients who have had seizures, are under sedation or anesthesia, stroke patients with swallowing disorders, also anyone with gastric distension or who is lying supine for long periods.
The outline mentions a concept called silent aspiration. That sounds incredibly ominous.
It is the most dangerous kind because there is no coughing, no choking, no turning blue. Small volumes of saliva or regurgitated food just quietly slip past the vocal cords and into the lungs.
And the patient doesn't react.
The patient doesn't react because their protective reflexes are dulled or absent.
So you don't even know it's happening until they spike a fever and have a new infiltrate on their chest x-ray.
Exactly, which is why prevention is everything. You have to assume at-risk patients are aspirating until proven otherwise.
Let's run through the nursing checklist for aspiration prevention. What's number 1?
First, screening. If a patient has had a stroke or has been intubated for a long time, you must consult speech therapy before you put anything in their mouth. They need a formal swallowing screen.
Okay. Number 2.
Positioning. We sound like a broken record, but it's so important. Head of the bed, 30 to 45 degrees. Keep them upright or semi-recumbent for eating, and this is keep them upright for at least 30 to 60 minutes after eating.
Don't feed them and then immediately lay them flat to change their sheets.
Please don't. Let gravity do its job. Wait.
Got it. Third, tube feeding safety.
You have to check the placement of the tube before every feeding, and you have to assess for residuals.
Okay, explain residuals for the new students listening.
Sure. If a patient has a stomach tube, like an NG or a PEG tube, before you give a feeding, you aspirate the stomach contents with a big syringe to see how much food is still sitting there from the last feeding.
And if there's a lot?
If you pull back 500 milliliters of fluid, that tells you the stomach is full. It's not digesting and emptying properly. If you then pump more food in on top of that, it's going to back up the esophagus and go right into the lungs.
So if the residual is high, the protocol is often to hold if it's over a certain amount, like 150 or 250 millibel, you stop the feeding.
Right. You pause the feed, notify the provider, and figure out why they're not tolerating it. And you should avoid bolus feedings, dumping a whole can in at once for these high-risk patients. A slow, continuous drip is much safer.
And lastly, for the intubated patient, cuff management.
The cuff is the little balloon on the end of the breathing tube that seals the airway. It needs to be inflated to just the right pressure. If it's too soft, secretions from the mouth can leak around it and go down into the lungs.
But if it's too hard...
You can cause tracheal necrosis. You can kill the tissue of the windpipe. So it's a delicate balance. But here is the critical pro tip for nursing students. Suction the hypopharyngeal secretions, all the gunk sitting on top of the cuff, before you deflate the cuff for any reason.
Of course.
Otherwise, the moment you deflate that balloon, all that junk slides straight down into the lungs like a waterfall.
That is a great visualization. It's like a trapdoor. Clean the top of the trapdoor before you open it.
Precisely.
Okay, we have arrived at the final critical turn in this story. The patient hasn't improved, the atelectasis worsened, the pneumonia spread, the aspiration caused severe damage. Now we are looking at acute respiratory failure.
This is the end of the line for the body's compensation. The lungs can no longer provide adequate oxygenation or ventilation to sustain life. It is a sudden, life-threatening deterioration.
We diagnose this with numbers, right? From the ABGs, the arterial blood gases. What are the criteria?
Generally, the definition we use is a PO2 less than 60 millimeter Hg, that's hypoxemia, and or a PaCO2 greater than 50 millimeter Hg, with a pH of less than 7.35. That's hypercapnia with acidosis.
The 50-60 rule, roughly. Oxygen under 60, CO2 over 50.
It's a good rule of thumb to remember. It means the gas exchange mechanism has failed.
What are the early signs? Before the blood gas comes back, what does the patient look like?
Restlessness.
Restlessness. Not just I'm in pain, but I can't get comfortable picking at the sheets.
Restlessness, anxiety, fatigue, headache, a feeling of air hunger. I cannot stress this enough for every new nurse listening. Restlessness is the key early sign of hypoxia. The brain is the first organ to notice low oxygen.
So if a patient is restless?
If your patient is restless, picking at their lines, anxious, check their oxygen saturation first. Do not just assume they are in pain or agitated and give them a sedative. If you sedate a hypoxic patient, you stop their drive to breathe and they will arrest.
That is a write it on your hand tip. Restlessness equals hypoxia, check first.
Absolutely. The late signs are the more obvious ones. Worsening confusion, lethargy, central cyanosis, and eventually respiratory arrest.
Management here is aggressive. We're likely looking at intubation inserting an endotracheal tube.
Correct. The objectives are to correct the underlying cause, if we can, and to restore gas exchange immediately. We intubate to secure the airway and hook them up to a ventilator to do the work of breathing for them.
Once that tube is in, how do we verify it's in the right place? Because we definitely don't want it in the stomach.
There are several steps for immediate verification. First, auscultate for bilateral breath sounds. You should hear them equally on both sides.
If you don't.
If you only hear sounds clearly on the right, you might have gone too deep into the right main stem bronchus, which is a common mistake.
Yeah.
You also listen over the stomach. You should not hear air gurgling there. Then you use an end-tidal CO2 detector, or capnography. It changes color as CO2 is coming out of the tube.
Yellow means yes, right?
Yellow means yes. Purple means problem. But the gold standard, the definitive confirmation, is the chest X-ray. You need that X-ray to see that the tip of the tube is sitting about 2-3 centimeters above the carina. That's the point where the trachea splits into the two main bronchi.
Once they're intubated, we talked about suctioning, but there are rules. You don't just suction on a schedule like every 2 hours.
Never. Never routine. You only suction when it is needed.
Why not? Wouldn't keeping it clean all the time be a good thing?
Because suctioning is a traumatic procedure. It sucks out oxygen right along with the mucus. It can irritate the tissues and cause bleeding. It can cause bronchospasm or even increase intracranial pressure. You only do it if you hear adventitious breath. Sounds like raunchy. If you can see visible secretions in the tube. Or if the high-pressure alarm on the ventilator is going off because of a clog.
And most places use inline suctioning now, the closed system.
Yes, a closed system that's wrapped in a plastic sleeve. It allows you to suction without disconnecting the patient from the ventilator circuit. This is much safer because you maintain their PEEP and their oxygenation during the whole process.
Finally, the goal of intubation is hopefully extubation, getting the tube out.
That's the victory lap. That's what we're always working towards. But it has to be done carefully.
What's the process?
You explain the procedure. You have a bag mask device ready at the bedside just in case they fail. You suction the patient thoroughly, remember the trap door, and then you deflate the cuff.
Give them 100% oxygen beforehand, too.
Hyperoxygenate them, yes. Then, on their exhale, you pull the tube smoothly. Afterwards, you immediately sit them up, high Fowler's position, give them some heated, humidified oxygen, and you monitor them like a hawk.
What's the big danger sign post-extubation that we need to watch for?
Stridor. A high-pitched, musical wheezing sound that you hear in their neck on inspiration. It means the airway is swelling, shut laryngeal edema. That is a true medical emergency. You might need to re-intubate them immediately.
It sounds like constant vigilance is really the theme here, from start to finish.
It really is. It's all about watching for those subtle changes.
So let's recap. We started with the simple mechanics of atelectasis, the shallow breathing and mucus plugs that collapse the alveoli. We then moved to pneumonia, the infection that fills those sacs with fluid and pus, and we talked about the crucial distinctions between CAP, HAP, and VAP.
We covered the VAP bundle elevation, sedation vacations, DVT prophylaxis, ulcer prophylaxis, and that crucial oral care as the shield against those nasty hospital-acquired infections.
We looked at complications like empyema, the silent threat of aspiration, and finally the complete breakdown of the system in acute respiratory failure.
It's the whole slide, from start to finish.
So what does this all mean for the learner, for the nursing student listening right now? What's the big takeaway?
It means that respiratory care isn't just about administering meds or oxygen. It's about mechanics. It's about physics. It's about recognizing that a patient lying flat is a patient at risk. It's about knowing that restlessness isn't a behavior problem, it's an oxygen problem.
So the nurse is the one standing between that patient and the slide into failure. Whether it's just handing them the incentive spirometer for the 10th time, or brushing their teeth, or noticing that grandma is suddenly confused, those are the life-saving moments.
Exactly. The intervention seems so small, so basic: sit up, cough, drink water. But physiologically, they are the things that are keeping the lungs open and clear and preventing disaster.
Before we sign off, here is a final provocative thought for everyone to mull over. We talked about sedation vacations in the VAP bundle. It's evidence-based, it's proven to help. But think about the tension there. We sedate patients to keep them comfortable, to reduce their metabolic demand, and to keep them from fighting the ventilator. But by doing so, we might be keeping them sick longer, we might be increasing their risk.
It raises a fascinating ethical and clinical question, doesn't it? Are we prioritizing comfort over recovery? Or are we finding that difficult balance where a little bit of scheduled wakefulness, even if it's uncomfortable for them, is what ultimately saves their life? That balance between rest and mobilization is where the art and science of critical thinking in nursing really happens.
Something to think about during your next clinical rotation. That's it for this deep dive into lung defense. Keep breathing, stay curious, and we'll see you next time.
Take care, everyone.